For those of you who don't know, have never ventured there, this is Wales. It's the landmass west of England. It's got a population of 3.5 million people and has 12 consultant-led units, for which Cardiff is the tertiary referral centre. If you do fancy going, it's got some fantastic scenery and a great culture. It's even got its own language. So this was me in 2004. I'd just been appointed a consultant at UHW, which is the abbreviation for University Hospital of Wales, and shortly after had an emergency caesarean section for my second child. This was 2004. The 2004 RCOG guidance had been published, and I duly got 5 days of enoxaparin post-discharge, and I was wearing, as you can see, anti-embolic stockings until I left. What didn't happen so well was when I was readmitted on day 6, having just finished my 5 days of Clexane, was an automatic offering of Clexane upon readmission. So we were doing some things quite well, and some things obviously were not entirely embedded. So I was then appointed as the lead for the UHB for thrombosis prevention, along with an interest in obstetric haematology. So I really wanted to nail thrombosis prevention in this population. Between 2004 and 2009, we worked hard on getting risk assessments and trying to get compliance with risk assessments and monitoring generally the compliance rather than the outcome of our work. And then the RCOG published the 2009 update, which, as I'm sure you all know, asked us to assess multiple risk factors and then decide when to offer thromboprophylaxis, whether it was antenatally or postnatally, according to what risk factors were present at the time of delivery. So whilst I was pondering that, the obstetricians, the obstetricians and the midwives approached me separately with some concerns about the new guidance and were we really going to do this. So on the left we have Julia Saunders, who's now a professor of midwifery. We knew at the time that 22% of adults in Wales were obese, and during the period that we're going to mention, we had about 50% of women booking for pregnancy in our institute had a BMI over 30. She was concerned that there wasn't much new evidence in the updated guidance to make us keen to change our practice, and she was really concerned about the cost of implementation and also the resource. At that point in time, we were still using our midwives to ensure that the postnatal thromboprophylaxis was given, although that obviously changed to being patient given through the subsequent years. We also had concern from our obstetric anaesthetists because obesity was such an emerging problem in South Wales at the time. Their concern was the increased morbidity associated with general anaesthetic in a woman who may have had thromboprophylaxis with low molecular weight heparin in the preceding 12 hours. And they were concerned that there wasn't the clear benefit for these women to be receiving ambulatory thromboprophylaxis. Whilst we were pondering, so we did NICE publish their guidance on VTE prevention across the board for hospitalised patients, and they limited their advice primarily to women who'd previously had a VTE who were recommended to have antenatal thromboprophylaxis and for the 6 weeks postnatal, but then focused on women who were being admitted to hospital. And these were clear guidance that said consider offering low molecular weight heparin if any one of those factors were present in a woman who was admitted for any reason during her pregnancy or postpartum period. So we decided to get a little group of us together, and we looked at the evidence of what had been published to date, some of which has already been highlighted. This was in the original 2009 RCOG guidance, which showed, I think, that there were differences in risk within the populations. They were very high risk, and we all accept that VTE in a previous pregnancy or previously has a higher risk of thrombosis. But you can see, as Dr. Sultan mentioned, the high confidence intervals with these odds ratios. For example, for the obstetric hemorrhage, with an adjusted odds ratio of 9, you went from 1.1 to 71. And this is reflecting the rarity of thrombosis during the pregnancy cohort. In that guidance, stillbirth wasn't recorded as a risk factor. Then you sort of drop down a category to significantly increased and probably significant with caesarean section, preterm live birth and pregnancy hypertension, and weight over 120 kilograms. So I thought I would go and do some detective work, and one of the papers that I was most struck by, again, has just been mentioned, and this was a registry data collection over a period of 5 years in New South Wales, and it reported on 510,000 deliveries, and it was looking at the risk factors for postnatal pulmonary embolism, but it rather looked at most of VTE risk factors. They had a very similar incidence of PE as we did in the UK at that time, and a very similar mortality. So I thought this was a fair group to refer to. Interestingly, they had a very, very similar sort of top 5 group, with SLE figuring as significant high risk of thrombosis during pregnancy, the postnatal period. Transfusion of red cells and coagulation factors comes up as a significant risk, stillbirth and obviously VTE in a prior birth, although you can see that in this study the odds ratio is much lower, but with still massive confidence intervals, and they pointed out in their paper that there was only one case in 230 postpartum PEs who had a history of prior VTE. When they looked at the risk according to mode of delivery, there was a clear increased risk associated with caesarean section on the top line compared to vaginal delivery. But when they looked at the difference between caesarean section during labour and without labour, there was no significant difference. And of course, the 2009 guidance suggested that you needed an extra risk factor if you'd had an elective caesarean section. In the 2004 guidance, we'd embedded a process where everybody who'd had a caesarean section then got postnatal thromboprophylaxis. And then there were the sort of very low increased risk of uncertain significance, of which smoking, parity, and small for gestational age were figured. So we then looked at our data for the year of 2009 and said, well, have we got a problem? Are we failing currently? And so this was what we found. We'd had a number of DVTs, 5 DVTs and 2 PEs. One woman was known to us and knew she was supposed to take thromboprophylaxis, but she was in denial and had a VTE before she actually presented to services saying she was actually pregnant. 4 women had no risk factors, and one had a adenocarcinoma with a pleural effusion, and she died whilst ventilated on ITU, and that was her cause of death. We did have one VTE-related death during that year, and that was a cerebral sinus thrombosis in a woman with antiphospholipid syndrome who was on postnatal thromboprophylaxis in her 4th pregnancy, having had a stillbirth in her 1st pregnancy. We haven't included cerebral sinus thrombosis in our assessment of thromboprophylaxis efficacy. So with all that data in mind, we got together and we developed our own risk assessment tool for pregnancy and the postnatal period, and we wanted to make it simple. I think one of the things about the 2009 guidance was that people really struggled with it. People would come up to me with frowns and saying, should we give this or should we not give it? And so we wanted to simplify it as much as possible, and we didn't really change much antenatally from what we were doing previously. So clearly if somebody had had a previous DVT or PE, they were offered thromboprophylaxis. If they had antithrombin deficiency that had been found through family studies, because obviously if you had antithrombin deficiency through having had a venous thrombotic episode, you'd be on long-term anticoagulation. We don't have a very big sickle cell cohort in our community, so we decided to put them into the high risk category. I know subsequent to that, the move has been away from routine thromboprophylaxis. Myeloproliferative disorders, similarly, we offer thromboprophylaxis routinely. For SLE, we asked that they were all referred to see myself or my colleague in the obstetric haematology clinic for discussion of the pros and cons of antenatal thromboprophylaxis. And because of the lack of evidence of efficacy in SLE, we offered it at any point in time from the period of booking right through to delivery and postpartum. But we would really strongly urge them to have it at least postnatally. Antiphospholipid syndrome, again without a history of venous thrombosis, would be offered aspirin and low molecular weight heparin. And we weren't brave enough to ignore the RCOG guidance completely, and so we thought that based on the CMAC and Embrace data, the very, very high BMIs were associated with increasing mortality. And at that point in time, as I said, it was a burgeoning burden to us, the obesity in our area. The cut-off for the referral to the obstetric anaesthetic clinic was 45 kilogram per metre squared. So we said, we're treating these people as ultra-high risk, let's do the same and offer those without question thromboprophylaxis antenatally. We then had a simple focusing on when people were admitted to the ward, either during pregnancy or in the postnatal period, any of these risk factors, and an admission to hospital during pregnancy or postpartum would receive thromboprophylaxis. And then we really, really wanted to focus on the postnatal period. That's the time where the biggest risk occurs and probably where things can easily get missed. So we listed a PPH greater than 1,500 mils, a red cell transfusion or transfusion of any coagulation factors. It's been our practice for at least that duration of time to use fibrinogen concentrate for resuscitation in postpartum hemorrhage, and so we were quite keen to ensure that any increased risk associated with transfusion of fibrinogen was mitigated with thromboprophylaxis once they'd stopped bleeding. And we decided to stick with our current practice of using thromboprophylaxis for elective or emergency caesarean section. We added in stillbirth, the BMI, sepsis, and a complex vaginal delivery. All women were asked, or the staff on the ward were asked to complete this before women left the delivery ward so that the risk assessment was complete. Any woman who was already on antenatal thromboprophylaxis obviously continued for 6 weeks postpartum. We did not change at that point from a duration of 5 days postpartum. As I said, more about the ability to do it on a resource basis. When the 2015 guidance came out, we moved to the 10 days because I think there's emerging evidence for the increasing risk for a prolonged period postpartum. Just as we had signed this off in the health board and felt quite pleased with ourselves, we were contacted by 1,000 Lives Plus, and 1,000 Lives Plus is the Welsh Quality Improvement Programme. And they were setting up a mini collaborative for all the health boards to join to focus on sepsis and VTE. And so the intention was to get all the mini MDTs together from each health board to work together to produce something that would reduce the risk for both and be able to reduce the variation across the East in Wales. We are lucky we're small and we should be able to do things on an all Wales basis. We're probably the same size as a suburb of London, so we should be able to work it out. The intention really before we started was to implement VTE risk assessment based on the 2009 guidance. The output was actually a policy exemplar guide which was based on the Cardiff and Vale risk assessment process and was signed off by 1,000 Lives Plus and by the NSAG, which is the sort of regulatory group for obstetrics and gynaecology in Wales. It was branded as a minimum standard, so if people in their local hospitals wanted to implement the RCOG guidance or differ in some way, they were quite welcome to do that, but it was badged as something that was accepted to implement across the whole of Wales. I have no information on what has been done. I do know that most health boards subsequently produced their own risk assessment pieces of paper that are in the notes, but this was embedded into the All Wales maternity pathway for antenatal care. So we promised the 1,000 Lives Plus that we would audit and we would report back if there was any adverse signals to this. And so we reviewed the incidence of pregnancy-associated VTE in Cardiff and Vale between 2009 and 2015. We wanted to know whether our local guidance was being followed and then whether any cases that had occurred would have been possibly prevented by the implementation of either the 2009 guidance, or we looked at 1 year, 2014 to 15, with the 2015 guidance to see if we should be changing our practice. And we had a system embedded where we could identify through a very complicated system anybody that had been admitted or attended an obstetric care and had a VTE, or either by Doppler ultrasound or radiologically for a PE, and we could cross-link that. What we do is look for 3 months postpartum, so that we're collecting our HAT data at the same time, which we have to report to Welsh Government and do a root cause analysis to see if there's anything preventable. We then identified women who'd had event and reviewed any letters on the clinical portal, which is our electronic system, from either haematology or obstetrics regarding the risk factors. We looked at the anaesthetic documentation, and we reviewed the UHB obstetric database, which gives things about the patients, such as BMI, smoking, and medical conditions. And then we reviewed the prescription for thrombosis prevention. So did we do what we thought we were supposed to do? Was it implemented? And compared the two guidances with our own. So between that time, we had 42,000 women booking for pregnancy at Cardiff and Vale, and we had 35 episodes of VTE occurring in 34 pregnancies. So that's an incidence of 0.08%, which is there or thereabouts for those quoted for pregnancy. And 32 women were diagnosed with VTE. What we found was that 8 of those women, so that's 23% of events, occurred in 7 women who had prior history of VTE and for whom guidance was for thromboprophylaxis was in place. And I'll talk about those more in a minute. And 9 of the women, that's 28%, had no identifiable risk factors for the first episode of VTE. When we looked at the women who had a prior history of VTE, our guidance said yes, low molecular weight heparin was indicated. They were all receiving low molecular weight heparin, except for one who'd received it antenatally and then it got dropped off postnatally for no obviously good reason, and she had an event at 3 weeks postpartum. We had one lady who had an apparent recurrence. This was a clinical diagnosis of a PE, so we can't confirm that. At the time, she was on enoxaparin 40 milligrams BD. She'd had an early event at 8 weeks gestation, and our practice at that time was to give 3 months of full dose and then drop it down to an intermediate dose of thromboprophylaxis. So she was fully involved with myself and as an obstetric haematologist, and since the RCOG guidance regarding treatment of VTE during pregnancy, we've changed our practice to maintaining full dose anticoagulation until 6 weeks postpartum. We had one lady who was on therapeutic low molecular weight heparin and had a clear recurrence at a new site on 1 milligram per kilogram BD of Clexane. Just gone back. So when we looked at when women did get an event, they were about 50-50, so 50% occurred in the antenatal period and 50% in the postnatal period. And when we looked at the risk factors for women who had an event, I excluded women who were on thromboprophylaxis with a prior history of VTE, because I was trying to capture those women that we would be capturing in this the multiple risk factors assessment. So 46% of women had no risk factors at all. 27 had one risk factor, 20% 2 risk factors, and 7% had 3 risk factors in the antenatal period. And then when I looked at the postnatal risk factors, 18% had none, 27% 1, 55% had 2 risk factors, and no people had 3 risk factors postnatally. When we looked at the actual risk factors, there were 4 women who had a history of a first-degree relative with a history of VTE. 4 of them were over 35, 3 were multiparous, 8 were smokers, and when I looked at how many they were smoking, there was no more than 1 to 2 a day admitted for any of those women. We had 2 with multiple pregnancy and 1 with reported phlebitis. What I thought was quite interesting was the medical conditions that we saw in these women for whom we were attributing a medical condition a risk factor. We didn't have any people with inflammatory conditions or SLE. We had people who gave a reported history of asthma, and usually when people say asthma, they sometimes use a puffer and they've never been to ITU. It's not usually a big problem for them. We had 1 lady who presented through the psychiatric unit and was dehydrated and psychotic at the time of her VTE. 1 lady had a recent appendicectomy, 1 with a recurrent miscarriage, and which was just reported. It wouldn't obviously figure as a risk factor for giving somebody thromboprophylaxis, a gestational diabetes, and somebody with a known anticardiolipin antibody, and I don't know anything more about that as to why we knew about it and why she might not have had thromboprophylaxis. When we looked at the BMI in these women, we had 20% of women had a BMI between 30 and 35, and 19% of BMI over 35. And when we looked at that in our cohort between 2014 and 15, you can see that the top line shows you the percentage of women with a BMI over 35, and that's sort of tracking along at 20%. So we didn't actually see any clear signal for BMI in the women who had an event. Bearing in mind that our morbidly over 45 were given thromboprophylaxis. 6 women had had a spontaneous vaginal delivery, 4 a section, and 3 of those were elective caesarean section. So when we looked against the RCOG guidance 2009, no patient would have been managed differently who had an event. And similarly, when we looked against the 2015 guidance for 1 year, no person would have been managed differently. So subsequent to that, we continue to monitor our rates of pregnancy-associated thrombosis. We've had no cases in the subsequent 2 years. We presented our data locally and to the All Wales Maternity Network, who are both happy that we continue with our current practice. We're waiting for NICE to update its guidance. We will be adding IVF as a risk factor for admissions. That's me done. I'd just like to thank Amy Shakaluga, who collected all this data, and it was quite a piece of work, and the MDT at Cardiff and Vale.